I can see your slides, Obiora. Just need to.
Oh, you can?
Yeah, you just need to go to full screen and start presenting.
Yes. So, just want to just start with talking about a 44-year-old woman who had right breast cancer, and who had come to see her doctor for her second course of chemotherapy. And there was one breakdown at the right breast mastectomy site, and they had no peripheral veins. So they contacted me to see if I could help them get access, which I did. And this is the post procedure spot check. Sorry, there was a bad detector in the cath lab that I used. But the reason I want to talk about this is because right now there's for most chronic illnesses, cardiovascular and diabetes, there is usually an accompanying renal dysfunction, and preservation of as much reserve venous access is important as time goes on. Also for arteriovenous fistulas. So it's good for us to have an idea of what's available and not to be wasteful in how we access people who have how we access the veins, or people who have chronic ailments. So I just want to talk about a few things. The indications for medication for TPN, if you have to give blood, if you have to give chemotherapy, dialysis, and repeated blood sampling. The only absolute contraindications for access with the device is basically cellulitis or allergy to the particular material used to make up the catheter. And then the common sites are the IJV, subclavian, which is not really popular anymore, but surgeons seem to kind of like it. The EJV, femoral, transhepatic, translumbar, and then of course peripheral veins. We have short-term versus, and we also have long-term catheters, and we have tunneled and non-tunneled. Tunneled tend to be more long-term because this the skin acts as a barrier and allows the device to stay for a longer time. And then we have single lumen, and we also have multi-lumen, which can be double or triple. And then, so yes, another way of classifying them can be peripheral, cannulas, midlines, PICC lines, non-tunneled, tunneled, and then tunneled dialysis catheters, and then chemo ports. And just for those who are not familiar, this is just a schematic diagram showing that a midline is a device that will go from the cephalic or from the cephalic to just to the axillary or the basilic vein, and it does not go all the way to the junction, the venocaval junction, the junction between the SVC and the atrium. While the PICC line goes through a peripheral vein and ends at the junction between the SVC and the atrium. And then a tunneled catheter would go, a tunneled catheter, whether chemoport or the other CVC, will go directly through the IJV and terminate at the junction between the SVC and the right atrium. So the things that will determine what kind of catheters that we use will be how long we intend to use the catheters for, because chemoports and long-term catheters tend to last. They can go all the way, if properly maintained, up to a year. Also, PICC lines tend not to go that far. They tend to go about 3 to 6 months. So if you were going to have repeated chemotherapy, you would not really want to use a PICC line for that if you were thinking of using it for a year. Also, this depends on the viscosity, because if it's a very thick thin or very caustic medium like chemotherapeutic agents, you'd want it to go directly into the right atrium as opposed to going to a peripheral vein, which would now cause some thrombosis and some irritation. And then again, if you were giving drugs that required, that were not compatible, you would need a double lumen as opposed to a single lumen. Like everything, we need to do a proper history taking, physical examination. That will determine where we want to access and why and how we're going to access that. Ultrasound is very good. We always make sure that we have the standard baseline INR, PT, PTT, and platelets, and then to do hepatitis and HIV screens to protect ourselves and to protect our staff. We can access in plane or out of plane, depends on you, on what you like. Sterile probe coverage is required. For sake of time, I'll just skip this. Standard cell data technique is done. We just have this represents the lumen, and then we access the needle, and then pass in the guide wire, and then we just exchange with a dilator, and then we now pass in the carrier tube. So I'll just talk about I'll just talk about one of them, and then from there I'll just talk about the others. So
sorry to interrupt, Dr. Obiora. 3 minutes are left.
3 minutes are left. Okay. Okay. So just what I just want to highlight is there seems to be an increasing case of complications in my country in terms of chronic total occlusion, and I just want to highlight that when we do the procedure, we always need to make sure that we land and we place our devices in that junction between the SVC and the atrium. This way, we don't have occlusion later on. And then just to show people who are not familiar with the devices, this is a tunnel catheter. Again, it's placed at the junction between the SVC and the right atrium, and a chemo port, which with the bell over here, and same proper placement there. Complications are divided into early complications and late complications. Early complications will be infection and malpositioning, and late complications will be fibrin sheets, central venous thrombosis, catheter pain chop, and fractured device or embolized devices, which we have to go and retrieve. I just, so my thoughts are that we should guide our colleagues so that they know the proper devices to ask for. We should always be willing to help them place this, because it also improves the outcomes with the multidisciplinary approach. For example, with dialysis or with chemo, with oncology. We should also help run workshops to teach our nurses, because if the nurses and the patients know how to preserve the devices, then this goes a long way in improving outcome generally. And because we have a problem in the West African region, we're not able to get certain accessories regularly. So if we cannot get tuber needles for the chemo ports, maybe we should consider using hubbed long-term catheters. These are the things that I was just thinking about when I decided to do the talk. Thank you very much.
Okay.
Thank you, Obi. That has been wonderful. You know, I know these are very small things for you. You have taught us a lot of venous interventions and these lines. So we have picked up our program of permacats. I do remember you helping us out for venous punctures and other things at our place.
Okay, thank you, Dr. Obiora. Thank you for also thinking about preserving these resources. These venous accesses are resources. So it's good that someone is thinking about them. So in terms of education, do you think that simulation can help in making the learning curve steeper? So what's your opinion on that?
Simulation, like simulation workshops?
Yes, yes.
Yes, I think that would go a long way. In APVIC, we actually have, that's what the vascular course that I take actually does. And the more you get used to accessing their ultrasound or doing it via simulation, the easier it is for you to do the real thing. Yeah.
Operators, can operators be single operators doing the ultrasound as well as the puncture at the same time?
Yes, I actually tend to work alone depending on where I'm working. So I actually take my access and I do basically everything by myself. It's faster if I have someone to help, but I can actually do the whole procedures from beginning to end. I just need a tech or radiographer to help me with the CM. So someone asked a question about the DSA. I didn't take a DSA. The problem is that not every cath lab in my country is equipped with DSAs, and sometimes you have to work with what's available. That's what happens when you're working in a resource deprived region. And I thought that would just be good to show that you have to use what you have and work with what you have. So for that particular image, there was no DSA available. I think there was a second question. What is the shrine in your last slide? The shrine. I don't understand what that means.
No, Obi, I think that was meant for someone else.
Okay.
The previous presenter.
Oh, sorry. Okay.
Nice to see you again, Obi.
Yes, nice to see. Fantastic presentation. I loved your presentation. Great.
Thank you.
Okay, thank you.
The APVIC has helped me see my son, who is in England, and I'm in Nigeria.
Thank you, sir. Thank you, Samira. Thank you, everybody.
I said it's very happy. I'm very happy and privileged to see all my people who worked with me previously and people who have worked, I have worked closely with. And it's a very proud moment for me. And also, we'll have another very good interventional cardiologist who trained under me, Dr. Idafe Emmanuel. So I think he's here, and he would be speaking on endovascular treatment of SFA pseudoaneurysm in Nigeria and his experience.